How is it that we find ourselves surrounded by such complexity, such elegance?
The genes of you and me, the genes of you and me, are all made of DNA. We're all made of the same chemical DNA. We're all made of DNA. We're all made of the same.
Hi, you're listening to DNA Today, a podcast and radio show where we discover new advances in the world of genetics. From genetic technology like CRISPR to rare diseases to new research, we have you covered. For a decade, DNA Today has brought you the voices of leaders in genetics. I'm Kira Dineen. I'm a certified genetic counselor and your host. Did you know up to 75% of all cancer drugs will not work for a specific person because of their unique genetic profile? And half of these people who are resistant to a drug have a known mutation or pathogenic variant. That's why pharmacogenomic testing is key. TrueGene Diagnostic offers detailed pharmacogenomic testing so drugs can be personalized based on someone's genetic predispositions. TrueGene Diagnostic maps out millions of data points to know the best matched drug per patient based on resistance and, for the first time in history, sensitivity. For patients with HER2-positive cancer, it's vital to start drugs that have the best chance of effectively fighting the cancer. By doing so, it drastically increases the patient's chance for survival. Stay tuned for an upcoming episode featuring an interview with the founder of TrueGene Diagnostics, who dives into the data with me. In the meantime, check them out at truegenediagnostics.com. Again, that's truegenediagnostics.com. In this episode, we're learning about Unity Screen non-invasive prenatal testing, or NIPT for short. I might slip and say NIPS by accident because I'm so used to saying that in clinic. But we're focusing on this for recessive conditions, so a little different than you might be thinking. So joining me are two experts from BillionToOne, the CEO, Oguzhan Atay, and the Senior Director of Medical Affairs, Jen Hoskovec. Stay tuned for our part 2 about their new fetal antigen NIPT as well. So thank you both so much for coming on. I'm excited to dive into this somewhat new technology.
Thanks for having us.
Thanks for having us.
So Oguzhan, can you share a little bit about what is Unity Screen and why you chose the name Unity?
Definitely. Unity Screen is a non-invasive prenatal screen, not only for aneuploidies, but also for single gene disorders like cystic fibrosis, sickle cell disease, and thalassemias that are typically screened through carrier screening. And that component of Unity Screen is a carrier screening with a reflex to a cell-free DNA test that allows us to know whether the fetus is high risk or low risk to be affected by any one of these conditions. And I think Unity Screen is a really good name because it really streamlines and unifies the screening workflow for prenatal care by combining all of these different conditions into kind of a single workflow, single blood draw. And it also kind of, I think, removes a lot of the inequalities that are actually traditionally found in the, especially the carrier screening component that requires the paternal screening, which is not always equitable in the United States.
Yes, that's a very good point that I'm sure we'll come back to at some point. And Jen, to bring you in, we've talked about now like what NIPT is and really expanding on the types of conditions that we can screen for. It's not just now Down syndrome, trisomy 13, 18, sex chromosomes. Like we're just expanding a lot more in the last couple of years. But when is it recommended for pregnant people to have NIPT, or when they should consider testing?
Yeah, so as you alluded to, NIPT is an approach, a screening approach, right? And we're very used to hearing about NIPT or NIPS or cell-free DNA, all alluding to the same approach for Down syndrome and similar chromosomal abnormalities, right? And that is routinely offered to all pregnant patients, right? And our NIPT for these recessive conditions is appropriate when a patient is identified as a carrier of one of the conditions on our panel. So cystic fibrosis, spinal muscular atrophy, sickle cell disease, other beta hemoglobinopathies, and alpha thalassemia. And as Ozan mentioned, we actually make it easy for the provider because we do the carrier screening piece first. And once the patient is identified to be a carrier of one of those conditions, we automatically run the single gene NIPT portion of the test and provide the fetal risk assessment. So this really is a frontline screen for any pregnant patient who is interested in knowing if they are at an increased risk to have a baby with one of these common inherited conditions.
So it's really shifting what a normal approach is, where we would have carrier screening, we'd get the results back. If it's a large panel, that person's probably going to be a carrier for 1 to 3 conditions, is tend to what I see. And then you're looking to test either the sperm donor or, the paternal samples, possibly the father, different roles here. And sometimes, as Ozan alluded to, they're not always available, or insurance gets in the way. So there's so many things that can prevent that part, but you're saying you don't even need that part to know if the partner is a carrier, because you can just go ahead and test the cell-free DNA of the pregnancy at that point. So some people might be thinking, well, how often does that happen? We hear a lot about the risk of, say, Down syndrome. That's one that a lot of people are familiar with, especially when I'm meeting with patients, and I bring up my NIPS, NIPT slide. They're like, oh, Down syndrome, that's the one I recognize on the slide, right? I think most people are aware of Down syndrome at this point, but less people are aware of recessive conditions. So what's the risk of having a pregnancy actually be affected by a recessive condition? Not the chance of someone being a carrier, but the chance for a pregnancy to actually be inheriting a recessive condition, like you mentioned, cystic fibrosis and sickle cell.
Yeah, so the kind of combined probability of a baby being affected by one of these conditions is actually collectively even more common than Down syndrome. And the carrier rates are actually almost 1 in 6 pregnancies found to be a carrier just by the ACOG recommended conditions as well. So it does create, I think, a lot of burden to really try to test the mother, test the father, do all the follow-ups up in the traditional carrier screening workflow. And really the unfortunate thing is that even though they are kind of more common or as common as Down syndrome, and with potential treatments and improvements as well now with all the upcoming therapies, there is a significant percentage of pregnancies that are being missed due to kind of various problems in a multi-step workflow that we alluded to. So by kind of streamlining this workflow, I think we can really make a large impact in being able to detect these disorders. And it might come across almost as a surprise that these disorders are kind of as common as Down syndrome, especially when we look at it collectively. And I think part of that is because these are a little bit of hidden disorders in some ways, right? When a baby is delivered, it is almost immediately known whether the baby has Down syndrome or not. But it is usually the newborn screening with a different provider, with a pediatrician, that is coming back as the baby failing the newborn screening. And by that point, a lot of the times OBGYNs don't even know that during that pregnancy a particular disorder was missed. And that's kind of a really salient point, because we have these conversations with some of the OBGYNs, and when we ask how many cystic fibrosis cases that you have had in the last 5 years, usually they would say that I haven't had any in even 10. That's not because that is a rare disorder. That is because we are really missing these affected pregnancies when we really require this multi-step workflow that requires the paternal sample.
Yeah, I think that's a very good point, in that even with testing out there, such as saliva kits that you can mail to someone's house, sometimes someone lives in a different country or someone doesn't want to do testing, and that's certainly their choice. But if the pregnant person wants that information, their partner doesn't want to do the testing, this is a way that we can have this information, as well as a lot of other situations. That's just kind of one that comes to mind that can happen sometimes. So as a genetic nerd, I have to nerd out a little bit to understand more of how this is actually working in your lab, because
I mean, the concept of cell-free DNA still blows my mind, and I've been talking about it for 10 years. I mean, we had this when the show started around 2012. I think it's when cell-free DNA was starting to be used in the clinic. So that still blows my mind. So that, a lot of them were either looking at, you know, extra or missing chromosome conditions or huge chunks of chromosomes missing, or a fairly large chunk. This, you're looking at one letter different. So how are you able to pick up these very tiny changes, especially knowing that if you're looking at these recessive conditions, the pregnant person themselves has one of these variants that you're looking for? So, I mean, explain this to me. How does this work? Because you have to have, I would imagine, a lot of data, and you've got to get really specific with it.
Yeah, I mean, it requires essentially almost a complete approach change into cell-free DNA testing. I think it has been kind of a very brute force approach until very recently, as you alluded to. It's kind of, we have problems even picking up million base pair changes, and now we are talking about being able to do this at a single base pair resolution, being able to detect that single letter change. And but when you kind of think about the problem from a first principle perspective, it is actually relatively straightforward, right? There are only two potential cases that you need to think about. One of the cases is when the maternal and paternal mutations are different. So in that particular case, it is just a detection problem. So you are, instead of kind of trying to quantitatively count anything, you just essentially need to see in cell-free DNA if there are any mutations that don't belong to the mother. So that would mean that not only the father of the baby is actually a carrier, but also that the baby has inherited that mutation. So that would bring your risk to actually 1 in 2 already better than what kind of a traditional carrier screening would be able to do. And a lot of the kind of cases are just that, compound heterozygotes. But the place where I think we do really well is when we look at the maternal location. And that is a more difficult problem, as you said, because you already have that background that is coming from the mother. So it's not just about being able to detect something, it is being able to quantify that particular location. And what we have really done is essentially we have perfected the method of quantification of cell-free DNA. So we developed a technology that allows us to count DNA molecules at a single count level. And then if you can do that, then the problem becomes really straightforward, right? All the maternal contribution is going to be 1-to-1. So if there are 2,000 molecules that have, let's say, the most common cystic fibrosis mutation, F508 deletion, there are going to be 2,000 molecules that don't have that mutation. And if the fetus is also a carrier, the fetal contribution is also going to be 1-to-1. So when you count the molecules, you will find that there are equal numbers of wild-type normal molecules and the mutant disorder molecules. If the baby is affected, if the baby has 2 copies, one from the mother, one from the father, that have the same mutation, when you count the number of molecules in the maternal blood, you will see an excess number of molecules that have the mutation. Right? You'll see, let's say, 2,400 molecules versus 2,000 that have the mutation. So you convert a biology problem to essentially a mathematical problem. If I see an excess number of molecules that have the mutation, what is the probability that the baby is affected? And the way that we count these molecules is essentially understanding that any molecular biology process amplifies the DNA. And everyone essentially looks at that amplified product. But at that point, you already lost a lot of the information. So what we do is essentially to remove that amplification bias by adding essentially like molecular rulers into the sample. We are adding these single molecules into the sample that are artificial DNA molecules. So after we amplify the sample, we know exactly how much amplification happened. We can measure everything against those individual molecular rulers that we had added at the beginning of the process. So now we can count molecules at the single molecule count level. And as I explained, once you can count molecules, the problem is actually really straightforward.
It's just math. I'll leave it for someone else, but someone else can do it. So you're using this artificial DNA as kind of your control to see like, well, if everything is amplified to this point, let's see what our control is. And then you can, I'm probably making this somewhat simple, but subtract how much extra there is from it. And then, I mean, as you were bringing up, looking at ratios, like a lot of, this type of NIPS and NIPT is looking at ratio based, of looking at how much of the, pregnant person's DNA there is compared to the pregnancy. So it's interesting. And I would think also if you have, that's all talking about if it's the same mutation, like say, the Delta 508 that you mentioned for CF, that's a very common mutation that we see. But you could also have a different mutation. So I imagine if you're picking up a new mutation, you're like, well, that has to be coming from the other parent. So that probably makes it even easier. You probably have to do a lot less math in those cases.
Yeah. That part, finding those compound heterozygotes is the kind of relatively easy part. It is a little bit like liquid biopsies for cancer, right? That has been in the field for the last few years, really transformed kind of cancer therapy selection by being able to find out what mutations are coming from the tumor so that the right targeted therapy can be prescribed. So kind of that component is actually almost one-to-one similar to the liquid biopsies for therapy selection. The part that is a little bit more difficult is when the maternal and paternal mutation might be the same, so you are really trying to quantify that maternal mutation to see if you see an excess number of molecules.
Are you also then saying we would like to have a paternal sample? Or are you like saying it's not even necessary at this point?
That's a great question, right? So really the way I look at this as a former prenatal genetic counselor, right, is that partner testing is always something that should be offered to anyone who is identified as a carrier of a recessive condition, right? However, what we recognize is with this particular Unity workflow, it is not necessary to provide that patient with a risk assessment for the current pregnancy, right? What it can be useful for is if that couple is planning to have future pregnancies together, it would then be useful so they know moving into another pregnancy if they are a high-risk couple. But it absolutely, reduces the urgency of needing that partner sample to know if this particular pregnancy is at an elevated risk or at a low risk, right? A lot of the reason we do screening is to provide patients with reassurance and comfort that they are low risk for these conditions that they may have heard about or have consented to testing for. And the other thing that it does is it really equalizes opportunities for patients that want this information, right? I think all of us have had conversations with patients about carrier screening with kind of this heavy heart of, I'm offering you this screening knowing based on what you've told me that it's probably not going to be as clinically useful as it is to other patients because your partner is unavailable, unwilling, or underinsured, or whatever the case may be, and unable to complete the process. So this kind of brings that, kind of fills that gap for patients and allows anyone who wants this information to get carrier screening and a subsequent risk assessment for that baby regardless of their situation.
And I think that's a good point because I know some prenatal genetic counselors that will only offer carrier screening if both parents are present and are going to do it together, which I understand the approach of that because for some patient populations, the follow through on that second parent is so low. And so there's so many issues of, well, now you've spent this money for the first parent and you don't have the information. So it's really a half answer, but this would really eliminate, for all of those prenatal genetic counselors that are facing this issue constantly, they might say, well, now I don't even need that other partner to be there because we could just have this reflex in place. So, you mentioned some of the disorders that you've included on this. Why did you guys decide to go with those disorders? I mean, obviously carrier screening really ranges. You can screen 1 to like over 500 conditions. So how did you guys figure out, okay, what conditions are we offering this, package carrier screening with the reflex?
Oguzhan, do you want to take that as the co-founder
I
here?
can take that. I mean, it's a clinical question, but
Yeah.
so we decided on those particular conditions because they are recommended for screening by American College of Obstetricians and Gynecologists. And one of the interesting things that we find out is that even when we talk with genetic counselors or maternal fetal medicine specialists and ask them about, would you want an expanded panel? And if so, what conditions we should include? And two answers that we commonly get, especially with OBGYNs, they usually say that they don't want an expanded panel.
I've heard it before. Yep.
It covers the most common genetic conditions that have actionability. But even with genetic counselors and MFMs, we sometimes, even for people who have been offering expanded carrier panels, they can't really decide which conditions should be there. And as a lab, we prefer not to be kind of arbiter of the truth and like, this is an important condition and this is not an important condition, and kind of make those decisions, especially because now we are moving one step forward and we are even providing that fetal risk assessment for these conditions. So that is why we just decided to kind of stick with the ACOG guidelines and cover those conditions. And of course, if ACOG guidelines are updated to include more conditions, we would change our panel as well as our reflex single gene NIPT to cover those additional conditions as well.
And so, go ahead, Jen.
I was just going to say, and I think as Oguzhan alluded to, it's really important to have a good understanding of why we're doing what we're doing and how useful it is from a clinical standpoint, right? I mean, I've had conversations with patients many times of just because we can do something doesn't necessarily mean that we need to or that we should. And if you look at the conditions on this panel, they occur with a relatively high frequency for a genetic condition. They are very well understood, right? And there are emerging therapies that are really, really important to know about for these conditions. Take SMA, for example, right? I mean, really incredible progress that has been made with these FDA-approved therapies for these pregnancies. And it really is changing the benefit of early identification and early diagnosis and counseling during a pregnancy and prior to a delivery for these families. And if you look at the conditions on this panel, all of them have some emerging therapy either during the pregnancy, right, with things like hemoglobin Barrett disease, or immediately after, and early intervention is key for something like SMA, for example. So I think that it's the clinical utility of carrier screening, that conversation is changing with these conditions in particular.
Yeah, I think that's a fantastic point. And just, understanding that, as you were mentioning that, I'm like, not only are these common conditions, but we've seen a lot of changes in terms of treatment. I mean, for SMA, I don't even know if we're allowed to call it a cure, but it's darn close to that. If you've been listening to DNA Today for a while, you probably know I'm also a full-time prenatal genetic counselor. Between that job, this podcast, and being a producer, host of other podcasts, I'm pretty busy. So to keep up my energy and stay productive, I drink a decent amount of coffee. Think like Lorelai Gilmore, but maybe not quite that much. The new coffee I'm drinking is from Four Sigmatic, and I'm really picky about my coffee. It's got to be bold, not watery. That is the worst. I still drink it if I have to, but it's not my favorite. And I have to say, I've been really happy with Four Sigmatic. Here's the difference from other coffees. It includes mushrooms, which I know sounds bizarre. I will admit I was hesitant, but you don't taste the mushroom at all, and you get the health benefits from it. I like the immune system boost as I often get sick in the winter months, so this is really important. And I wanted to team up with Four Sigmatic to get you 30% off using promo code DNA Today, and you can redeem it at foursigmatic.com. Again, that's four, spell it out, F-O-U-R, Sigmatic, S-I-G-M-A-T-I-C.com. Use code DNA Today for 30% off, and let me know if you like it too.
Which drug do you prescribe for your HER2-positive cancer patients? For the first time in history, True Gene Diagnostics informs you which of the 3 leading cancer drugs your patient is sensitive to and resistant to. TrueGene Diagnostic knows the functional effect of every mutation in the TK region of HER2 gene and knows the functional effect with and without the 3 most common drugs present, thus allowing you to match the best drug to the patient. Unlock the best drug for your patients with HER2-positive cancer using TrueGene Diagnostics. Check it out at truegenediagnostics.com. Oh, and stay tuned for our interview with them.
I mean, Spinraza is
Incredible.
just phenomenal, and it's just changed the game. I was in grad school when it came out, and I mean, we're just floored reading the studies and everything, and it's just absolutely fantastic. But as Jen was pointing out, it's really important to start that treatment early because you're preventing symptoms from happening. So that makes sense. You know, a lot of the same thought process of what should be on newborn screening that you guys have taken into account when looking at this. One question that, you know, you probably get from every genetic counselor, maybe some OBGYNs, MFMs too, is specificity and sensitivity. So we get to, you know, nerd out about statistics a little bit. So what does that look like for it, you know, to make it a little bit more user-friendly? Because it took me a while to kind of, you know, sink in with what each of those are. But, you know, let's take true positives, for example. If you have a pregnancy that you're saying is at risk for beta thalassemia, then how many of those end up being diagnosed with beta thalassemia? So what's your percent of like actual true positives over every positive that you call out?
So we actually recently published a paper specifically on, you know, outcome data, right? So what are we seeing with the carrier screen result or Unity screen result, and what are we seeing in the newborn period? And what we identified is the single gene NIPT approach, right, for the conditions across all of the conditions on our panel has a sensitivity of over 93%.
That's really high.
Right? It's
Wow.
great. Yeah, we're very excited. And of equal importance is the negative predictive value, right? When you're talking about a frontline screen, the negative predictive value is extraordinarily important, particularly if you're speaking to like an OBGYN where the vast majority of results they're getting are low risk, right? And the negative predictive value was 99.4% in this particular study. Of particular interest in kind of more to your question, what we report is a unique risk assessment for the pregnancy. So for example, that risk assessment for sickle cell disease may be as high as 9 and 10, right? It may be for cystic fibrosis 1 and 2. Those are different risk assessments, both significantly higher than where the patient started, right? And what we learned in this study is that the risk assessment provided on the report was an accurate representation of the likelihood the baby was affected. So for all of the reports that we released of a 9 and 10 risk in this study, all of those babies were affected, right? So of the bucket of reports that we released a risk of around 1 and 2, 48% of them were affected, and so on and so forth. So what that study did show is that the specific risk assessment we were providing was accurate and can be used in counseling those patients so they can make informed choices of next steps.
So I think my next question with that is we've been, you know, throughout the episode comparing, well, what is like a typical workflow where we do the carrier screening, we learn about that from both parents, and then we say, okay, well, you both came back as a carrier, now we're looking at doing like invasive testing, amniocentesis. So I think I kind of didn't mention that as part of the workflow there. So expanding upon that, you know, I have plenty of couples that were in that situation, and so then we do an amniocentesis so that we can have fetal cells to test. That's got to grow in the lab, takes a long time. You know, talking weeks, which is a long time during a pregnancy. It's very timely. Every day, week matters. So when we're looking at this, are you, you know, I guess what are recommendations from BillionToOne, you guys, your company, in terms of for these couples that have that high risk? Are you recommending that they then confirm that with an amniocentesis?
Absolutely. Yeah, this is a screening test, right? And it's intentionally designed to be a screening test. However, what I will say is that it's a screening test that is providing a much more specific risk for that pregnancy. It's not a static, well, you're both carriers, so you have a risk of 25%, right? It's not the same conversation with each family or even with each pregnancy with a single family, right? It's unique and specific to that pregnancy. So what that allows them to do is just have a bit more confidence in what that true risk is for their baby and provides them with more information to then make decisions with. But diagnostic testing should be offered to patients. And if they choose not to have diagnostic testing, then what I think this allows, and I hear a lot of providers say, well, it's on the newborn screen anyway. Yes, but the newborn screen takes time, right? And if we know a baby is high risk for SMA, we don't need to wait for the baby to fail the newborn screen. We can specifically order, right, molecular testing within hours of life and confirm that diagnosis much quicker. So it can provide streamlined and personalized care regardless of what the patient's decisions are.
And then on the flip side, go ahead, Oguzhan.
Oh, I was just going to add, in terms of comparison in the study, one of the, I think, really impactful things that we have done was to look at that direct comparison with traditional carrier screening and this new workflow of carrier screening with reflex single gene NIPT. And there are two remarkable things that came out of that. One of them was that the sensitivity of single gene NIPT is so high, it's like 93.3%, that even if someone was able to implement a perfect carrier screening workflow, just because of the misattributed paternity rates in the United States, you would miss more affected pregnancies, even with 100% compliance and every single father being tested, using the traditional carrier screening workflow compared to carrier screening with reflex single gene NIPT. And if you consider that almost half of the actually paternal samples do not get tested, even when the mother is a carrier, which was a UT Health MFM group did a study around this, then you are looking at actually maybe only 1/3 of affected cases that are being detected in the traditional carrier screening workflow. So it really increases the sensitivity of being able to detect these disorders from a workflow end-to-end perspective, all the way from being at 30% to more than 90%. And that is, I think, a really remarkable change, because if you think about the quad marker screen versus NIPT for aneuploidies, that was a big difference, but at the end of the day, it was a difference from going from 90% sensitivity to maybe 99% sensitivity. What we are talking about here, I think, is actually an even bigger change than what has happened kind of with that NIPT for aneuploidy change. And from that perspective, we really think that this can become the next standard of care. It is actually a bigger improvement than what happened with quad marker screen versus NIPT for aneuploidies. And today, not many providers offer quad marker screen anymore. So
I haven't seen that in a long time.
Yeah, from a futuristic perspective, we really think that kind of the standard of care will slowly move towards having a more comprehensive cell-free DNA-based testing.
And for people that end up having a result where you're saying there's a low chance that baby has, you know, the condition that the pregnant person's a carrier of. I mean, a lot of people, I can imagine, if I was counseling them in that situation, would say, well, now I don't think I actually want to pursue an amnio because I feel more comfortable with my risk level. What are your thoughts on that, especially Jen coming from, you know, the prenatal genetic counselor background? I mean, this is a screening test, but when we have a screening test for, say, Down syndrome and it's low risk, if someone said to me, now I don't feel the need to do an amnio for Down syndrome, is there parallels here? I mean, would you feel comfortable and you feel like the patient has enough information to say, you know, I'm declining an amnio?
Absolutely. You know, I mean, I think if you think about it, the average patient who comes in and is a carrier of a recessive condition and we don't have information on partner, we're giving them a risk assessment. And the vast majority of my patients didn't pursue amnio in that case. And we are dramatically reducing that with this assay where we're looking at sequencing and dosage analysis, and we're able to provide a significantly decreased risk. And if you look at our study with a 99.4 negative predictive value. So I absolutely think they're parallels. In my mind, this is a similar approach as NIPT for aneuploidy to offer this to a general population of patients, provide significant reassurance for the vast majority who are low risk, right? The vast majority of carriers do not have affected babies, right? And then identify the ones who really do need to get in front of a genetic counselor and speak with maternal fetal medicine and be offered these next steps where we might not have identified that otherwise.
Yeah, and for those patients, I think, as you were saying earlier, it's important if they have that low risk to say, well, your partner could still be a carrier and this could just not be an affected pregnancy. So in those cases, you know, it's good for people to explore the option and have that option to do carrier screening for the other parent. But if they have, you know, a high risk and then they end up having a diagnosis, then that other parent is an obligate carrier at that point. So I think there wouldn't be, you know, a need to have that written on a piece of paper for that other parent. But yeah, I think that's, you know, important to kind of, you have to rework your workflow. I mean, it's really just simplifying the workflow. But it's very interesting.
Yeah, I think that's the key. Yeah, simplifying workflow as much as we can. If you imagine, you know, we're genetic counselors. So you mentioned nerding out earlier. I mean, that's what we do.
That's what this entire show is.
We want to talk about it, right? And we have, you know, anywhere from 20 to 40 to 60 minutes to sit down and talk to a patient about this. However, the vast majority of this screening is done in a frontline setting in a general OBGYN practice. And it is a very small piece of what they do. So the more we can simplify it and make it better for the patient and better for the provider, then it's a win-win.
I agree with that. I think that's a good note to end on. Thank you both so much for coming on and exploring this. And as Jem was saying, nerding out with me, because this really, I think, is going to change the game. And hopefully years from now, I'll be like, yeah, I interviewed them back in the day when this was really getting up and running. So this is very cool. I can see just how, you know, as we started saying at the top of the show, you know, just access to care. This is just going to help so many people in so many different situations, just a few of which we've touched on in scenarios where this is just very helpful and there's not an alternative. So thank you both so much. This is just really, really cool. Very cool advancement in prenatal genetics.
Thank you so much for having us.
Yeah, thanks for the opportunity.
For more information about today's episode, visit DNApodcast.com, where you can also stream all episodes of the show. We encourage your questions, comments, guest pitches, and ideas. Send them all into info@DNApodcast.com. Search DNA Today on Twitter, Instagram, YouTube, Facebook, so you can connect with us there. And a favor, please rate and review the podcast on Apple, Spotify, or wherever you listen. This truly helps us climb the charts and allow more genetic nerds like yourself to find the show. DNA Today is hosted and produced by myself, Kira Dineen. Our social media lead is Corinne Merlino. Our video lead is Amanda Andrioli. Thanks for listening, and join us next time to discover new advances in the world of genetics.
The genes of you and me, the genes of you and me are all made of DNA. We're all made of the same chemical DNA.